All right, welcome and good evening, and thanks very much for joining. This is the Southern African HIV Clinician Society, CME, on the 23rd of July, 2020. We have three outstanding speakers today. You are really privileged to hear from the caliber of people you're about to tonight. We've got first up an approach to patients with advanced HIV disease and suspected respiratory opportunistic infections from Prof. Gary Martins. That's going to be followed by a guidelines update about the new Cryptococcal Meningitis guidelines and particular emphasis on the new medications. That'll be from Professor Nelesh Govender. And then we'll next move on to Cryptococcal Meningitis case studies, and that will be led by Professor Yunus Musa and Dr. Richard Lessels. And then finally, we end off for the last 15 minutes with Q&As. And we're going to go through some of the questions that were sent in ahead of time and also take some of the questions that are available in the chat box as you go. So if you do have questions to any of the panelists about their talks, please do enter them in the chat and we'll try and answer some of them as we go. The experts will type replies as we go, and then we'll also deal with some of them in the Q&A session right at the end. So it really should be a fantastic evening, and it's like I said, an absolute privilege to have three such good speakers. The first speaker, I'm going to stop sharing my screen so you can start, but the first speaker is Professor Gary Martins. Let me see, there we are. Get exited there, there we are. The first speaker is Professor Gary Martins. He's head of the Division of Clinical Pharmacology at UCT and the Chief Specialist Physician at Relapse. He is well known to all of us. He's author of over 200 peer-reviewed articles, and his main research interests include therapeutic aspects of HIV-associated TB, drug-resistant TB, and antiretroviral therapy in resource-limited settings. One is that to reassure people that the slides will be made available on the South African HIV Clinician Society website, and that will be following this webinar. This is being recorded and will be uploaded there. Because again, and I did mention in the beginning, but just because of the large audience size, obviously we won't be able to take questions verbally, but as some people have started doing already, please do feel free to add questions in the Q&A box, and we'll take a sample of them at the end. And then in terms of CPDs, this is CPD accredited, and you will get emailed your CPD certificate after the webinar. An acknowledgement and thanks for all the support that makes this possible. So really the support comes largely from Unitaid, AbbVie, and Janssen J&J, with some support also from the Clinton Health Access Initiative and Isincha. And this is really makes these sort of webinars possible, and the dissemination of this knowledge really possible. And then lastly, just to mention some of the online courses that are available from the HIV Clinician Society website. There are, in particular, there's an advanced HIV clinical management course, which is for doctors, and that will include some of the really useful tips and tricks in terms of managing patients with advanced HIV in the Southern African setting. There's a similar course for nurses, advanced HIV management course, and there's also a pharmacy-initiated management of ART, the PIMART, so-called online course as well. And then just to flag you that there's another new one, and it's the Cryptococcal Meningitis online course, and part of Nilesh's talk will be uploaded to that. And it's going to be also, focusing as well on flucytosine as well, which will be a separate component to this all. And that will be, Nelesh will mention flucytosine in his next talk, but that's a separate module which will be really useful, worthwhile going. Okay, I'm going to stop sharing at this point so that Nelesh can share. And I just wanted to welcome Professor Nelesh Govender. And so Nelesh is the head of the Center for Healthcare Associated Infections, Antimicrobial Resistance and Mycoses at the NICD. It's a real mouthful, but he's head of it all. And he's also a member of the Ministerial Advisory Committee on Antimicrobial Resistance, and he's president of the Infectious Diseases Society of South Africa. He was a co-chair and is the co-chair of the two most recent clinical guidelines committees for cryptococcal meningitis. And he's coming to talk to us tonight about these latest guidelines that the guidelines committees produced. Thanks, Nelesh.
Thank you, Jeremy. Thanks for the introduction. Can I just confirm that you can see the correct screen?
Yes.
Okay, great. Thanks so much. So my aim is really to highlight some major shifts in the 2019 guideline, which is an update from the 2013 Clinician Society guideline. I've added a link here so people can have a look at the guideline in detail if necessary. As Jeremy's mentioned, I'm going to highlight some previously unavailable medicines, 5-FC and liposomal amphotericin B, both of which are now available through broadened access through a crypto meningitis program. And throughout this talk, I'm going to use a case to illustrate some points. So the case is that of a 43-year-old man who was seen at an Urban Hospital's HIV outpatient clinic. The patient was diagnosed with advanced HIV in late 2019, started first-line ART, and then interrupted treatment in March 2020 during the lockdown. He now looks clinically well and is keen to restart ART. So look, I've got some questions here. What would you do? Would you restart ART on the same day? Or would you examine him, order some blood tests, and ask him to return in a week? Would you berate him for interrupting treatment, or refer him for adherence counseling, or perhaps something completely different? So just a point to make is that there's really an ongoing high burden of advanced HIV disease in South Africa. This is a paper that was published a couple of years back, shows the proportion of patients entering care with advanced and very advanced HIV disease. And what you can see is that over the last few years, and this data goes up to 2016, the proportion with advanced or very advanced disease are roughly 33%. So a third of people presenting or entering into care with advanced disease. And so the WHO's consolidated various recommendations included in various guidelines into a single consolidated guideline, which was published in July 2017. And in this guideline, it defines advanced HIV disease as a CD4 count less than 200 or WHO stage 3 or 4 event among adults. And in this guideline is a package of care, including various interventions for screening and diagnosis, prophylaxis and preemptive treatment, as well as relating to ART initiation and adherence support. And I'm going to focus on cryptococcal antigen screening in this talk. You'll see in that 2017 guideline, the recommended threshold was less than 100, but that's been changed to less than 200 in the 2018 cryptococcal guideline. So South Africa was first to implement a national cryptococcal antigen screening program, which happened in late 2016. And we use a laboratory-based reflex screening model, essentially where patients have an initial blood draw for baseline CD4 count. And if the CD4 count is less than 100, a cryptococcal antigen test is automatically done on that same sample, and both CD4 and CRAG test results are reported simultaneously so that they're available to the next follow-up visit. So these are some summary statistics. Since this program began, almost 1 million CD4 less than 100 samples through our program, through our national CD4 program over this time period, and 99% of those samples had a CRAG test done. Of those, approximately 6% were CRAG positive, and that's just over 55,000 tests. And so when you take it down to patient level, that's about 750,000 patients screened, and almost 50,000 patients identified with cryptococcal antigenemia. We're currently evaluating this cryptococcal antigen screen and treat program through a project called Castnet at 446 facilities across the country. We've got through about a quarter of our data collection so far, but just based on preliminary data from about 500 patients, roughly 75% of those patients started fluconazole, and 79% of patients were alive at 6 months. We've certainly seen a decline in CRAG testing since the onset of lockdown, though the proportion positivity, or the percentage of positive tests, has increased. So this is data looking at February through to May over a 4-year period. 2020 shown in green, and what you can see is that although we tend to see decreases in CRAG testing in April, the CRAG testing numbers definitely have decreased in 2020, certainly below what was happening in previous years. When you compare weekly CSF confirmed cryptomeningitis, there's no difference. And that, of course, makes sense. We expect that patients who were not ill may not have accessed health services, but certainly patients with cryptomeningitis would have accessed care. So let's go back to our patient. So based on a careful initial assessment of this patient, he had no TB or meningitis symptoms. He had mild oral candidiasis, angular cheilitis essentially, and so was assessed as clinical stage 2. He was referred for adherence counseling, found to be very keen to restart, was committed to restart, and so restarted ART on the same day, given TLD, and baseline bloods, including a CD4 count, were done. So in this editorial, which was published in 2017, associated with a trial called the Reality trial, what was really interesting is that almost half of patients enrolled into this particular trial, where the threshold for participation was a CD4 count less than 100, had mild or no symptoms, and so essentially was staged to stage 1 or 2. And so this highlights the limits of relying on clinical assessment alone. And so if CD4 count, so it's important to maintain the capacity to measure CD4 counts. And so we're very lucky to have a very large program in South Africa. If viral load testing is available, we know that CD4 count is no longer required to determine eligibility for ART or to track response to treatment, but a baseline CD4 count is essential to assess the risk of severe disease, both in patients newly presenting for care and those who are presenting for care after treatment interruption. So essentially, follow-up assessment of this patient 1 week later was found to have a CD4 count of 89, and his reflex blood CRAG test was positive. Just to point out that you have to specifically order a CRAG screening test if your patient's CD4 count is between 100 and 200. That's because the reflex program still only tests patients with a count below 100. And also another point, CRAG screening is not specifically recommended among children aged less than 10 years of age. So what are your next steps? In the clinical guideline published last year, we've got an algorithm that deals with this. If someone is blood CRAG positive, they need to have a lumbar puncture. The lumbar puncture results then determine what is next done. So if the CSF is negative for CRAG, the patient can go on to 2 weeks of fluconazole and start ART immediately. If there's no consent for lumbar puncture, and if the patient is asymptomatic, the patient can start fluconazole and then start ART after 2 weeks of antifungal treatment. If the patient doesn't give consent for lumbar puncture but has symptoms of meningitis, you would then treat for cryptococcal meningitis. You may want to also consider CT brain if that's available, obviously. So what's new in the Clinician Society guideline? The screening threshold is now less than 200 and not 100. And this is regardless of whether the patient's ART naive or experienced. The reason for this was that when you look at both less than 100 and 100 to 200, the CRAG prevalence, although lower among patients with 100 to 200, there still is a relatively high prevalence of cryptococcal antigenemia. But more importantly, in a clinical trial, looking at cryptococcal antigen screening as an intervention along with community ART adherence support, you can see that in the subgroup analysis between 100 and 200, there was a clear reduction in mortality in this group, similar to the group below 100. Just to point out, the NDOH recommendation has not changed as yet, and the screening threshold is still less than 100. So the recommended approach in the Clinician Society guideline again is that reflex lab screening is preferred and not clinician-initiated screening. But as I mentioned, if you have a patient with a CD4 count between 100 and 200, because this is not shifted in the NDOH guideline, you'd specifically need to request this. An LP is also now recommended for all patients with a new blood CRAG positive test, regardless of symptoms, provided that there's no contraindication to doing a lumbar puncture. And this is really because 1 in 3 patients with a blood CRAG positive test have subclinical cryptococcal meningitis. In a study that we did, 12 of 37 patients who were asymptomatic had a positive CRAG test in the CSF, and this correlated or was associated to some extent with the blood CRAG titer. You can see that as the CRAG titer increases, the proportion with CSF CRAG positive test increases. So CRAG titers are very difficult to do. There's now a semi-quantitative CRAG assay, which is available. It's a little more difficult to interpret than the standard CRAG lateral flow assay because it includes an additional T2 line, which essentially disappears as the concentration of CRAG in the specimen increases. So you can see that the T1 line, as we know, will increase. You'll see more. It'll become more stronger as the titer increases, whereas with the T2 line, this tends to disappear with a stronger reaction. And what's interesting is that the MESQ assay correlates very well with the CRAG titer. You can see that there's almost a linear correlation here. So what we've mentioned in the guideline is that the blood CRAG titer more than 160, which may correlate to some extent with an SQ result of 3+ or 4+ if you're using that assay, may indicate a high risk of concurrent and subsequent cryptococcal meningitis and mortality in asymptomatic CRAG positive patients. And so particularly among those who decline a lumbar puncture, it's really important to monitor carefully for signs or symptoms of cryptococcal meningitis. Another research question which is being is under investigation by several trials, by 2 trials actually, is that CRAG positive patients, especially those with high blood CRAG titers, may actually need enhanced antifungal treatment. So in this particular patient, we have him restarting ART before his blood CRAG test was available. And so the question is, how do you manage a blood CRAG positive result after recent ART initiation? What you're trying to do here is balance up the risk of mortality as a consequence of CM iris versus stopping ART and the risk of HIV disease progression and drug resistance. Though the risk of drug resistance is probably lower with a dolutegravir containing regimen. So the guideline panel felt that there was clinical equipoise for this particular question. So essentially what we recommend is that if you have initiated ART in the 4 weeks prior to a CRAG positive result, you refer the patient immediately for lumbar puncture. If the CSF CRAG test is negative, you can safely continue ART and start fluconazole preemptive treatment. But if you've made a new CM diagnosis, whether you continue or stop ART is a difficult question to answer. And that, as I mentioned, is a research question. So you certainly would treat the CM, but the ART question is more difficult to answer. So what do you do when a lumbar puncture is contraindicated? If focal neurological features are present, obviously perform a CT brain first. And if clear features of a mass lesion are found, clearly a lumbar puncture should not be performed. But if these features are not present and there are no non-neurological contraindications, then you go ahead and perform a lumbar puncture using your clinical judgment. If the blood CRAG test is positive with signs of meningitis and a lumbar puncture is contraindicated, you should treat for cryptococcal meningitis, but also perform standard blood cultures and consider other causes of meningitis, such as TB. So Cryptococcus is without a doubt the most common cause of meningitis from a microbiology point of view. In this study that we did, 62% of incident meningitis cases were caused by Cryptococcus, followed by TB, pneumococcal pneumonia, and other bacterial pneumonia. The TB meningitis is obviously TB meningitis is obviously a very important cause of disease, but the diagnostic tests are perhaps not quite as good. So you clearly need to test CSF to confirm the diagnosis of cryptomeningitis. The diagnostic test that should be performed, a rapid cryptococcal antigen test and culture, and as I mentioned, also look for other causes of meningitis. It's also important to measure opening pressure. In this patient, it was 30, and normal is less than 20 centimeters of water. So up to 3/4 of patients with cryptococcal meningitis develop raised intracranial pressure. This is due to CSF outflow obstruction, and this may patients may present with this at diagnosis, or it may develop on treatment. The signs and symptoms are listed on the slide here. And there aren't any changes in the guideline in terms of management of raised intracranial pressure. The management is fairly standard, but what we have included in the new guideline is what to do if there's no manometer. We've provided several options if you don't have a manometer. Drop counting using a makeshift manometer, which importantly underestimates pressures, and also using the eyeball test. And so if a manometer is not available and the clinical symptoms or signs of raised pressure, the guideline panel advises that 20 to 30 mils of CSF is removed. So how should this patient be treated? Which antifungal agents and for how long? The ACTA trial has clearly shown us that 1 week of amphotericin B plus flucytosine is the best performing regimen, shown here in purple on this Kaplan-Meier survival curve. And so as a result, if you have a CSF that tests positive for any cryptococcal test, regardless of symptoms, the preferred regimen is now 1 week of amphotericin B plus 5-FC. If amphotericin B is unavailable, then 2 weeks of fluconazole and 5-FC. And if 5-FC is unavailable, then 2 weeks of amphotericin B and fluconazole, followed by fluconazole consolidation treatment. Just to notice that the fluconazole doses are elevated in the induction phase regimen, as well as in the consolidation regimen, and then on to maintenance for 200 at a dose of 200 milligrams. Remember that ART started after 4 to 6 weeks of antifungal treatment if the patient is ART naive. So previously unavailable therapeutic options include 5-FC and liposomal amphotericin B. As I mentioned in the ACTA trial, 5-FC clearly the most effective partner drug, and it's not yet registered in South Africa, but is available through Section 21 application. Liposomal amphotericin B, or ambisome, compared to deoxycholate, has a similar efficacy but less nephrotoxicity, is registered in South Africa but is very expensive, or relatively expensive compared to the deoxycholate formulation. And just to notice that there are different daily doses. So just in terms of the Mylan product, in December 2019, Mylan filed for registration with SAHCS and has offered a pricing of $75 for 100 pack of tablets. So just if you calculate for a 60-kilogram adult who needs 12 pills a day for 7 days, it works out to just over 1,000 rands for a course of flucytosine. I mentioned the South African CM access program earlier on. This was established in 2018 by the Clinician Society and MSF at 15 facilities. In 2020, the National AHD Task Team has decided to expand the access program to 50 facilities. National Section 21 approval has been obtained, and high burden facilities will be prioritized for expansion, with training and mentoring planned for the expansion facilities. So let's go back to the case. So this patient has a baseline serum creatinine of 250 micromoles per liter. Does this mean that the antifungal agents are contraindicated, or should dose adjustments be made? So in the guideline, we've mentioned what to do with dosage adjustments. You then use the patient's age, weight, serum creatinine to calculate the creatinine clearance, or GFR, and based on the GFR, in this case 31.7, decide on the dosage of amphotericin B, fluconazole, or flucytosine. So if the GFR is 30 to 50 moles per min, then you could use either a liposomal amphotericin B containing regimen with flucytosine if that's available, if liposomal amphotericin B is available. If it's unavailable, then to use deoxycholate and 5-FC, and in week 2 use fluconazole. Just remember that 5-FC and fluconazole need to be dose adjusted as per this table here. And as I mentioned, with liposomal amphotericin B, just make sure that there's no confusion between fungizone and ambisome, because they are very different doses. The dose for liposomal amphotericin B is 3 to 4 milligrams per kilogram per day. And there are specific recommendations for infusion, which I don't have time to go through. I want to also mention how this patient was treated with amphotericin B, 1 milligram per kilogram per day, plus 5-FC renally dose adjusted, 25 milligrams per kilogram BD. And the patient then received in week 2 600 milligrams of fluconazole per day. So the question is, how do you administer 5-FC? The dosage for the induction stage is 100 milligrams per kilogram in 4 divided doses. Nausea and vomiting may occur, but you can then prevent this by giving 5-FC pills individually during a 15-minute window. And just remember that 5-FC can cause bone marrow depression. We've got a dosing table in the guideline table. So that just gives you the number of pills based on the patient's weight, which is useful. And in terms of amphotericin B deoxycholate administration, I think that most clinicians are very familiar with this. This slide contains a 10-step checklist. The slides are going to be circulated, so I'm not going to take you through this, but it is helpful from a nursing point of view to use this checklist. Just remember that deoxycholate is toxic to the kidneys. It causes phlebitis, electrolyte abnormalities, anemia, etc. And so in the guideline, we've also mentioned laboratory monitoring based on the induction regimen that has been chosen, either the preferred regimen or one of the alternative regimens. And so for amphotericin B deoxycholate and 5-FC, combined the monitoring tests that are required. I've already mentioned when ART should be started after a CM diagnosis. In this particular patient, he had resolution of signs and symptoms. Remember, there's no need for CSF analysis at the end of an induction phase treatment for a first episode, though this is recommended for patients with multiple culture-positive relapse episode. So this patient was discharged after 14 days of treatment. So in terms of ART timing, as I mentioned earlier, it's 4 to 6 weeks after initiation of antifungal treatment, and this really is the data which drove that recommendation. How should a subsequent episode be diagnosed and managed? Really careful clinical assessment. A relapse means that you've got signs and symptoms of meningitis again. It's important to check adherence to fluconazole and ART regimens, both self-reported and pharmacy refill records. Is the intracranial pressure raised? Could this be iris because of with timing of ART? And just remember that with diagnosis of a subsequent episode of meningitis, you do need to repeat a lumbar puncture, do an opening pressure, and submit CSF for culture. The laboratory should be asked to incubate plates for at least 14 days. And remember that rapid tests are not useful for diagnosis. It's also important to exclude TB meningitis. The reason for India ink not being useful is because it's not clear if this fungus is dead or alive. In terms of iris, remember this affects 20% of patients with CM who start ART. It usually occurs within 6 weeks after ART initiation, but delayed cases may occur. Usually it occurs with recurrence of meningitis with raised pressure, and typically the CSF cultures are negative, but in some cases may still be positive if there's been recent induction treatment. And in general, the CSF white cell counts are much higher compared to the initial culture positive episode. We've got an algorithm for suspected paradoxical iris. In the text in the guideline, I've changed it into an algorithm in this slide, but I'm going to refer you to the guideline for reasons of time. So when should fluconazole resistance be considered? This is another change in the guideline. We've now recommended that this should be considered when there's at least one relapse episode and all other causes have been excluded. Remember that there are many causes of recurrences. If a reference or academic laboratory confirms resistance and fluconazole minimum inhibitory concentrations are found to be elevated, you can consider an alternative maintenance regimen, either high-dose fluconazole, so higher than the 200 milligrams, which is the standard maintenance regimen, other azole agents such as posaconazole, and that may be combined with or without weekly amphotericin B. I've got an algorithm about managing blood Crag positive results in pregnancy, but I'm not going to go through this because Eunice has a case related to that. And then my very last slide, just to show you some key differences between the Clinician Society guideline and the current National Department of Health guidelines. As I pointed out earlier, the threshold currently is less than 100 for the Department of Health guideline, but less than 200 with the Clinician Society guideline. There's some differences in terms of ART initiation timing if a patient is blood Crag positive. And the preferred regimens are different with the Clinician Society and the National Department of Health guideline. And the Clinician Society includes a few alternative induction phase regimens. Just some acknowledgements that I've listed on the slide, and thanks for your attention. Jeremy, over to you again.